Welcome, everyone. Today, we're going to tackle a really critical topic, bridging that gap between the operating room and the pediatric ICU. We'll be diving deep into the essential cardiovascular and respiratory principles you absolutely need to know to manage critically ill children. Our goal? To ensure every single transition of care is seamless, safe, and successful.
Hello, anesthesiologists. Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. The principles and the guidelines we're about to cover really are foundational for anyone caring for critically ill kids, and they're going to provide the framework for everything else we'll discuss.
So here's our roadmap for this explainer. We're going to take a structured journey through 5 key areas. First, we'll talk about bridging that all-important gap between the OR and the PICU. Then, we're going to get into the real nuts and bolts of pediatric cardiovascular and respiratory management. After that, we'll do a quick tour of other critical organ systems and then wrap it all up by distilling it down to the most important clinical takeaways for our practice.
Okay, let's get right into our first section, the PICU-OR interface. Now, this is about so much more than just 2 departments being next to each other in a hospital. It's really about building a seamless, uninterrupted continuum of care for our most fragile patients.
You know, it's pretty fascinating when you think about it. Pediatric intensive care actually grew out of the world of anesthesia. Now, of course, we've both evolved into these highly specialized fields, but our paths are constantly crossing, especially as we see more and more complex patients. And this right here, this transition of care between our 2 environments, the OR and the ICU, it's a major point of vulnerability for our patients. So what's the non-negotiable solution? Excellent, absolutely seamless communication. This isn't just about being polite. It is a critical safety procedure. And that's exactly why so many leading institutions now mandate attending-to-attending handoffs. The core principle is simple, but it's incredibly powerful. A successful patient outcome is fundamentally tied to a successful handoff.
This quote really is our North Star. A seamless transition isn't just a nice idea. It's the safety net that we build around the patient with every single piece of information we share. We have to make every single handoff count. It's also important to understand that when we hand a patient over, we're not just giving a report, we're integrating them into a very specific culture. The modern PICU really operates on these core tenets. Family-partnered care is huge. There's a structured, multidisciplinary team, a real commitment to transparency, and above all, an intense, relentless focus on safety. And our handoff, it's the first and maybe the most critical step in that whole integration process.
All right, let's switch gears and move on to our second section. We're getting right to the heart of the matter, literally, pediatric cardiovascular management. Honestly, understanding the fundamental developmental physiology is the absolute key to mastering this area. Everything else builds on this foundation.
Okay, this slide right here is one I want you to burn into your memory. It perfectly lays out the huge differences between a baby's heart and a mature heart, and it explains the why behind so much of what we do. Look at the neonatal side. The heart muscle is made of stiff, less compliant fibers, and it has way fewer contractile elements. This has a massive clinical implication. It means it doesn't stretch well. It can't just easily increase its stroke volume when you give it more fluid. It's not like an adult heart in that way at all. And that brings us to the most important line on this slide. Cardiac output is rate dependent. For a neonate, their ability to increase cardiac output is almost entirely about increasing heart rate. That is their main compensatory mechanism. It's why a baby's first response to any kind of stress, hypovolemia, hypoxia, pain, you name it, is tachycardia. They are also incredibly sensitive to any changes in afterload. So, when you're managing a neonate's hemodynamics, you have to think rate, 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 and be extremely careful about anything that might crank up their systemic vascular resistance.
So picture this. You're faced with a crashing child. What is your absolute first priority? This isn't a time for guessing or trying things randomly. The answer is a rapid, systematic approach. We need a playbook, and thankfully we have one. Let's look at the gold standard for this situation, the sepsis resuscitation pathway.
This timeline, which comes from the Surviving Sepsis campaign, is our battle plan. The clock is ticking, so let's walk through it. In those first 5 minutes, it is all about recognition, noticing that altered mental status and poor perfusion, and then acting fast. Get IV or IO access and start that first fluid bolus. From 5 to 15 minutes, we're tackling metabolic problems like hypoglycemia and hypocalcemia, getting antibiotics on board, and probably considering a second fluid bolus. Now here's the critical decision point, between 15 and 60 minutes. If the patient is still in shock despite the fluids, it is time for vasoactive support. We don't wait. For cold shock, think epinephrine. For warm shock, it's norepinephrine. Then, if we're past that 60-minute mark and still struggling to hit our MAP goals, we have to start thinking about catecholamine-resistant shock and aggressively hunt for other mechanical causes, like a pericardial effusion or a pneumothorax.
This brings us right to our pharmacologic toolkit. It's so important to match the right drug to the right physiology. Epinephrine, with its potent alpha and beta effects, is our go-to for low-output, cold shock. For that warm, vasodilatory shock with low SVR, norepinephrine is our first line. Dobutamine is a great choice when the primary problem is myocardial dysfunction, but you have to be careful as it can cause vasodilation and drop the pressure. And for those really tough cases of catecholamine-resistant vasodilatory shock, vasopressin can be a key rescue agent. Knowing these specific roles lets us tailor our support with incredible precision.
Now, we spend a lot of time talking about hypotension, but it is just as critical to have a good framework for the opposite problem, severe hypertension. And this table gives us a fantastic differential diagnosis. You can see that by far the most common cause is renal disease, but we can never forget the other categories, especially the ones that are most relevant to our practice. A neurologic cause, like increased intracranial pressure, has to be on our radar immediately. And of course, we always have to consider iatrogenic causes from the drugs we ourselves administer, like corticosteroids and sympathomimetics.
Okay, let's shift gears to Part 3, Pediatric Respiratory Failure. And the subtitle on this slide really says it all. This is the single leading cause of pediatric cardiac arrest. In kids, the airway and the lungs are almost always the first domino to fall. So mastering this topic is absolutely non-negotiable for all of us.
This is a really foundational slide. The first thing you'll notice is how dramatically the respiratory rate changes with age, right? A newborn breathing 50 times a minute is normal, but that would be alarming in a 12-year-old. But now look at the second row, the tidal volume per kilogram. It's remarkably constant at 6 to 8 milliliters per kilogram across all ages. This is such a useful piece of information for us, especially when we're setting up a ventilator. It gives you a reliable, safe starting point no matter how old the child is. The key takeaway here is to always know your age-appropriate respiratory rate, but you can trust the constant of a weight-based tidal volume.
It's also critical to remember that the cause of respiratory failure changes dramatically with age, and this directly impacts our anesthetic plan and our differential diagnosis. In newborns, you should be thinking about problems of transition and development, things like surfactant deficiency, meconium aspiration, or persistent pulmonary hypertension, PPHN. But in older children, the script completely flips. Now we're dealing with acquired conditions like asthma, bronchiolitis, or pneumonia. Knowing this distinction is really the first step in effective management.
So what happens when conventional ventilation just isn't working, especially in a patient with severe ARDS? Well, that's when the PICU team might turn to advanced rescue strategies like high-frequency oscillatory ventilation, or HFO. The whole principle here is to use tiny tidal volumes, often less than the dead space, at extremely high frequencies. The strategy is to keep the lung open at a relatively constant mean airway pressure. This recruits alveoli while minimizing that damaging cycle of stretching and collapsing that we know causes ventilator-induced lung injury.
When the team is setting up HFOV, the initial frequency they choose is based on the patient's weight. And as this table shows, the core principle is a simple inverse relationship. The smaller the patient, the higher the frequency. So a tiny preemie might start at 50 Hz, while a teenager would start much lower, maybe around 5 or 6 Hz.
These principles of lung protection are absolutely paramount. And I want to stress this. They start with us in the operating room. This isn't just for the ICU team later. First, low tidal volume. We're talking around 6 milliliters per kilogram to avoid stretching the lungs too much, which is called volutrauma. Second, we have to optimize PEEP to keep the alveoli from collapsing at the end of each breath. That prevents atelectrauma. Third, we have to watch our plateau pressure and keep it below 30 to limit barotrauma. And fourth, and this is so crucial, we must limit the driving pressure. That's the difference between the plateau and the PEEP. We want to keep that delta below 15. This single variable has been strongly linked to survival. Finally, in the most severe cases, using neuromuscular blockade can help achieve perfect ventilator synchrony and rest the lungs.
Now, beyond just the ventilator settings, there are several powerful adjuvant therapies we need to be aware of. Prone positioning is a cornerstone of ARDS management now. Inhaled nitric oxide can be used as a selective pulmonary vasodilator to improve oxygenation. Corticosteroids might be used to help calm down inflammation. For patients who are failing everything else, ECMO provides the ultimate form of support. And of course, none of this works without excellent sedation and analgesia. As anesthesiologists, being aware of all these potential next steps really helps us manage the patient's entire perioperative course more effectively.
Status asthmaticus requires a very clear, stepwise approach. At the core, we have the basics: oxygen, beta agonists, and steroids. If that's not cutting it, we move to escalation therapies. This includes things like continuous albuterol, IV magnesium, or even non-invasive ventilation. And this is where our unique skills become absolutely vital. Ketamine is an excellent choice here for its powerful bronchodilatory effects. Finally, as a last resort, we have the rescue therapies. This includes intubation and ventilation, where our potent inhaled anesthetics like sevoflurane can sometimes be life-saving. And in the most extreme cases, ECMO may be the only option left. Excellent. Let's move on to part 4 now for a really crucial overview of other critical organ systems. The thing is, when a child is critically ill, no system is an island. Everything is connected. We have to maintain a holistic view.
The Pediatric Glasgow Coma Scale is just a fundamental tool of our trade. What's so important about it is that it adapts the standard GCS for pre-verbal children, which is absolutely essential for an accurate assessment. During a handoff, being able to communicate a clear GCS score, for instance saying the patient's GCS is 8, E2, V2, M4, provides a standardized, objective measure of neurologic function. It cuts through any subjective descriptions. It's a common language that we all must speak fluently for patient safety.
When we're managing a child with a traumatic brain injury, our mission is crystal clear: prevent secondary injury. That's our whole game. And that means we have to be absolutely fanatical about avoiding hypotension and hypoxia to maintain cerebral perfusion pressure. Our choice of anesthetic here is critical. Agents like propofol and etomidate are fantastic because they decrease the brain's metabolic rate, which in turn reduces cerebral blood flow and helps lower that intracranial pressure. Now, ketamine has been controversial in the past, but more recent data suggests it may be safe in very controlled settings. When ICP remains high, the ICU team will then escalate through their tiered therapies, usually starting with hyperosmolar agents like hypertonic saline or mannitol.
Let's take a quick look at the renal system. There's a really key clinical pearl here for newborns. Notice that the serum creatinine is initially pretty high. That's because at birth, it's just reflecting the mother's creatinine. A healthy term newborn's creatinine should fall pretty rapidly over the first few days of life. If it doesn't, that's a huge red flag and an early sign of renal dysfunction. Also, take a look at the expected urine output. It's higher in infants, around 1 to 2 milliliters per kilogram per hour, than in older children.
So when does a patient with acute kidney injury actually need dialysis? Well, these are the classic urgent indications. The big ones are severe fluid overload, especially if there's pulmonary edema that just isn't responding to diuretics. Life-threatening hyperkalemia is an absolute indication to call nephrology. Symptomatic uremia, meaning the patient has encephalopathy or pericarditis, and severe refractory metabolic acidosis also demand renal replacement therapy. Knowing these triggers helps us anticipate where the patient's clinical course is headed.
Okay, let's finish this section with a quick, rapid-fire review of 3 very high-stakes emergencies. First, for a child with DKA coming to the OR, the key word is control. Your fluid resuscitation and your insulin therapy must be slow and steady to avoid that dreaded complication of cerebral edema. Second, for a patient with congenital adrenal hyperplasia, or CAH, the major risk is an adrenal crisis. These patients absolutely require stress-dose steroids for any significant procedure. And finally, for a child in hepatic failure, you have to anticipate and manage the classic triad of hypoglycemia, a profound coagulopathy, and cerebral edema.
Okay, we have covered a tremendous amount of ground. So now, let's take all of this incredible information and distill it down into the most crucial, practical takeaways for your daily clinical practice.
If you remember nothing else, remember these 5 points. 1. Developmental physiology is destiny. You have to respect that rate-dependent heart and that fragile airway of a child. 2. Respiratory failure is the primary enemy. In pediatrics, a cardiac arrest is almost always a respiratory arrest first. Manage the airway, manage the breathing, and you'll prevent most codes. 3. Know your shock algorithms. A systematic, time-sensitive approach saves lives. 4. Lung protection starts with you, in the ER. The principles of low tidal volumes and appropriate PEEP apply from the moment you pass that endotracheal tube. And finally, number 5. Communication is a procedure. You have to treat the handoff to the ICU with the same rigor, the same focus, the same sterile cockpit mentality as you would any invasive procedure. It is that important. And this leaves us with a final thought to reflect on.
We spend so much time perfecting our technical skills, our intubations, our line placements, but maybe the next great frontier in patient safety lies in perfecting our communication. How can we, together, elevate the handoff from just a simple transfer of information into a robust, dynamic shield that actively protects our patients during their most vulnerable moments? Thank you so much for your time and your attention today.